We're going to touch on topics such as hormone replacement therapy for men and women. We're going to be talking a little bit about Ozempic and weight loss and how it affects the aging process. And we're going to talk about a few other things.
Do men go through menopause of some kind?
Oh, yeah. It's not as spoken.
It's not as spoken about.
The number one selling franchise in the US last year was a men's health center that focused on testosterone replacement therapy.
If you have the same calories throughout the day versus intermittent fasting and binging it all, it's still maybe better to do the fast because your body goes into a catabolic state, no?
Ozempic can help raise testosterone almost as much as going on testosterone replacement therapy.
Really?
By helping men lose fat.
If you go to Peter Attia's concepts of the 4 horsemen, it's improving all of the things that are going to eventually kill you. And how much of that can you reverse without hormone replacement as a man? Like if you were just to work out, change lifestyle,
Do you
reduce
think
alcohol.
Dr. Solomon's asking for himself?
Well,
sure.
I'm 56, so I want to know.
I feel like he's taken over my job here.
Hi, everyone. Welcome back to Unfiltered, our podcast. Today, we have a special guest, one of my friends and colleagues, Dr. Melissa Hirshberg. And today, we're going to switch gears a little bit. We're going to be talking about beauty, but we're also going to be talking about anti-aging. There's been a huge amount or a swell of information on the internet through other podcasts about longevity. And there's been a longevity conference recently in Toronto. And I thought it was worthwhile bringing on Melissa, who's an expert on longevity and anti-aging, amongst other things, to talk about longevity and how anti-aging paradigm can be paired with beauty. And so we'll start off with an intro to Melissa, and Nancy's going to be asking a few questions. We're going to touch on topics such as hormone replacement therapy for men and women. We're going to be talking a little bit about Ozempic and weight loss and how it affects the aging process and how that can be tied into some of the aesthetic treatments we do. And we're going to talk about a few other things. So I'll turn over the mic to Nancy.
Well, welcome, Melissa.
Thank you.
So today it's kind of fun because we're talking about aging and anti-aging from the inside out, a little bit of a different angle for us. So what would you say is the most common concern that you see when it comes to aging, living longer? What are people looking for when they come to see you?
So patients see me, like you mentioned, for their general health, how to live longer, and they also see me for their aesthetics, how to look better. So generally speaking, people want health span in addition to lifespan, meaning they want to age healthfully, look good, feel good, and live longer. So first and foremost, if you don't have health, you don't have anything. So the most important thing is to really focus on their particular family history, make sure that we're doing the proper screening. So we have the general, OHIP regulated, screening, things like mammograms, colonoscopies, getting your yearly blood test done. But in addition, they like to know about what else can they be doing for screening, what goes beyond, what's just covered in the public healthcare system. So we talk about that. And then they want to know how can they look great as well. So obviously these weight loss medications have become so popular to help women, especially and men, as they go through perimenopause, andropause, and all of a sudden notice that they're putting on weight, they have less muscle, they have less energy, lower libidos. So what can they do for wellness? So generally speaking, I help them with health and I help them with wellness.
Do men go through menopause of some kind?
Oh,
too?
yeah. It's not as spoken.
It's not as spoken about.
So the number one selling franchise in the US last year was a men's health center that focused on testosterone replacement therapy and obviously things like Viagra and Cialis and those medications, because a lot of men, middle-aged men, they start feeling like they're not as well muscled, they don't have the same energy, they don't have the same vigor, and they want to get treated for that. Now, they don't say, I'm going through andropause. It's not as much of a buzzword, but certainly they have a drop in testosterone levels. Not as much as women have the drop in estrogen, but certainly not the way they were when they were in their 20s. And now, people want to feel like they did in their youth. So yeah, they definitely do go through it.
I have a question about that. So with men, is it a vicious circle? So they start to drop just with the natural aging process and their testosterone and muscle mass both go down? Or is it that the testosterone goes down, their muscle mass goes down, their energy goes down, they don't work out, and it becomes a bit of a vicious circle?
Exactly. So number one, they stop exercising. They stop lifting weights as much as they get older and busier, especially in their 40s and 50s when, you're focusing on, working, you need to support yourself, you're busy, you're taking care of aging parents, and you're taking care of younger kids. So they put on some fat. The more abdominal fat you have, the lower your testosterone is going to be as well. And you're not getting good sleep. And you may be drinking more alcohol. So things in their lifestyle like less weightlifting, less exercise, more alcohol, more abdominal adiposity leads to lower testosterone. Lower testosterone leads to less energy, less muscle mass, more fat. And so absolutely, it's a vicious circle.
And how much of that can you reverse without hormone replacement as a man? Like if you were just to work out, change lifestyle,
Do you
reduce
think Dr.
alcohol?
Solomon's asking for himself?
Well,
sure.
I'm 56, so I want to know.
I feel like he's taken over my job here, so I assume there must be some interest.
We have both middle-aged people here. You can ask the female stuff. I want to ask the male stuff.
no,
I pretend it's not happening.
So how much can you reverse?
So I read a study recently that showed that Ozempic can help raise testosterone almost as much as going on testosterone replacement therapy.
Really?
By helping men lose fat.
That's
So
very
actually, so I don't know if it's, or just doing it on your own,
How
of
is
course.
that possible?
Because you have less aromatase if you have less abdominal fat. And so their testosterone goes up. And then often as people start losing weight, then all of a sudden they have healthier habits as well. They can't drink as much. All of a sudden they want to go to the gym. All of a sudden they want to do those things. They
you get
maybe
that
then
positive
have
feedback.
a better, more sexually active, the more you do that. These are things that can help. I mean, obviously it's still good to have a blood test done and some, you can't just say, oh, just lose weight and your testosterone will go up. You have to keep track of it. It's individual for everybody. But
so here's, there's so much to cover on the topic of longevity. So I'll try to move relatively quickly just to get through a lot of stuff. So on testosterone, just a couple of last questions. If someone gets a blood test and their testosterone's low and they've done everything else and they go on testosterone replacement, are they on it now forever? Is it going to reduce further your own endogenous testosterone? And how will it affect prostate health?
So it depends. It also depends on their age. So if you're still looking to have children, then no, we wouldn't typically put somebody on testosterone continuously because it could shut down your own production of testosterone, and that might affect your future fertility. So often when it's a man who's still in childbearing, well, I guess with a wife of child or looking to have kids, they may select other medications. HCG is one of them, but that's something to speak with, a particular practitioner in that area. Or they'll do pulses of it. You go on it for a short period of time and then go off it, and then they might go on it, and it's, to be monitored. Once you're done having kids, then a lot of patients just stay on it for the long term, similar to how women go on menopausal hormone therapy and don't necessarily need to come off. They can stay on it. And actually, in terms of prostate health, there hasn't been an increase in risk in prostate cancer for patients on testosterone replacement therapy. We obviously still monitor it.
What about prostatic hypertrophy?
It can worsen prostatic hypertrophy.
And can they be on a meds for prostate hypertrophy and testosterone?
Yep.
So you can do both.
You can take both. Well, you wouldn't take it. It depends on the type of medication that you were taking. So certain medications you might have heard of, like Flomax is a popular brand name of one of them. You could take that, but if you wouldn't be on a testosterone blocker for prostate health and then go on testosterone therapy, that wouldn't make sense.
We are now going to switch gears. We're going to talk about similar situation for females as they hit perimenopausal. So tell us a little bit about the type of stuff that you're managing on a daily basis with a woman who's approaching, say, late 40s, early 50s, who's noticing changes, thinning of hair, skin changes. You do some blood work and you find that they're entering into perimenopausal stuff. What's the, it's a huge topic. Just give us sort of a summary of the main considerations.
So I'll give you a common scenario. So a female comes into the office, she's in her 40s, and she says, something must be wrong with me. I just don't feel well. I'm gaining weight. I feel like my hair is thinning. I'm yelling at everybody. I'm not sleeping well. Something's wrong with my body. What's going on? Do my blood work. So I bring them in. I do their history. I do their physical exam. I do their blood work, and everything's great. Okay, this is a common scenario where we can't see anything obvious through like objective obvious evidence that something's wrong, but subjectively, they just feel that change inside. So usually what's going on is this transition, this perimenopausal transition, which can be up to 10 years long. It can start in a woman's like late 30s, early 40s, and often women don't go, I think the average age of menopause is like 51 or 52. So what's changing is just their internal hormonal milieu. So women are more complicated than men in many ways, but with specifically their menstrual cycle, right? Because before we ovulate, we have the progesterone's very low, and then up until ovulation, your estrogen's sort of climbing. But when we have a lowered egg supply as we age, we don't always ovulate as regularly as on time and with the same strength. So normally what happens before perimenopause is first 14 days of your cycle, your estrogen's increasing, it peaks, you ovulate, you feel great, and then it slowly declines, and then your progesterone starts increasing. They both come down, you menstruate. That's what usually happens. But in perimenopause, all of a sudden that menstrual cycle gets a little wonky. So you don't have the same ratio of estrogen and progesterone. So if you come in and I do your blood work, I might say to you, your estrogen looks okay, your progesterone looks okay, but maybe it's not what you're used to or the normal ratio. So, and also women like men in their 40s, they're busy with their kids, they're busy with their job. You know, they tend to gain weight as well, exercising less, and that can also affect their hormones. So usually this is where it's confusing because it's like, okay, nothing's overtly wrong, but could you benefit from a little bit of hormone therapy or a little bit of weight loss therapy and feel better? Probably. So we're starting to treat more and more women in perimenopause before they've actually hit menopause with a bit of hormone therapy and with microdosing this GLP-1 therapy like Ozempic. And we're seeing a lot of people feel a lot better.
Tell us, you mentioned GLP-1 inhibitors. Mm-hmm. Tell us, it's sort of the theme of, I guess, 2000s or whatever. And when we started hearing about the drug, it was used primarily for diabetes, and it was used for patients who had significant weight issues, and now it's being used almost as an anti-aging longevity type of medication. So are you seeing that people coming in that are saying that look like they look fine, but they want to use it for other reasons?
Absolutely. So first of all, just to give you the history on like GLP-1s, especially with me in my practice, because I've always done more, I've done weight loss medicine, I've written weight loss books, and I've been working to help patients lose weight for 15 years. So I've had patients on GLP-1s for diabetes for almost 10 years since they came out. About, I would say, 5-6 years ago, there was a drug called Saxenda, which is known as liraglutide, that was the first one approved for obesity. But we weren't that educated on it, so I started using it for patients, but very carefully and very selectively in patients that truly had obesity. Okay, a body mass index above 30 or above 27 with a weight-related medical condition. But we were still just a little bit nervous to use it, and it's a daily injection. Then all of a sudden, a couple years ago, we got Ozempic, which is the once weekly injection of GLP. And initially I had patients come to me from the US that said, give this to me. I'm getting it in Palm Beach. It's amazing. But we weren't really prescribing it that much here in Canada. So I was probably one of the first people to start using it off-label, the Ozempic, not for diabetics, but to help people lose weight. And it was like a game changer because a lot of people know what to do. That's not the issue. It's not like you're sitting there with somebody who's in their 40s and they're like, oh, really? I should eat vegetables and I shouldn't eat, 3 pieces of bread at night with butter. They know what to do. But the problem is their bodies crave it. And it's not about willpower. It's just about how it works on your brain and how it works to keep people full. So it almost changes your cravings, your taste perception. So I started using more and more Ozempic in patients that had, true obesity. And then we started to use it even more off-label in patients that weren't truly obese, but just didn't feel great. They felt like, this is not me. I am 10 pounds heavier than I ever was. I don't feel good. I don't feel like myself. And even though I'm not morbidly obese or obese on the scale, I want to try it. And when I looked at all the evidence on it and all the studies on it, I didn't see a good case for it doing harm. It has a very good safety profile. Yes, there are side effects like, nausea, heartburn, constipation, diarrhea. Those are the most common, but usually you can titrate dose accordingly to manage those symptoms or teach people what to eat to manage those. And the dose in studies for obesity is 2.4 milligrams. We're not looking at giving people 2.4 milligrams. Most patients that are taking this are taking 0.5 milligrams a week. So that's what we consider like microdosing, taking a small dose, not the dose that was shown in studies for the obese patients, and they're benefiting. And the way I view it, I compare it to SSRI, so antidepressant medication. So
is that the effect this has?
No, but the analogy is that if a patient comes in to me and says, I'm feeling anxious, I'm feeling like just not happy, I'm not as great. Are they clinically depressed? Do they need to be in the hospital with a severe depression in order for me to give them an antidepressant? No. Sometimes if they're just feeling a bit anxious, a bit depressed, they can still benefit from that medication. So what I'm saying is you don't have to be morbidly obese to benefit from this medication. Sometimes it might just be you have extra weight that's making you not feel your best.
But from a longevity point of view, what does this do?
Well, the only thing that's ever been shown to increase longevity is calorie restriction. So that's the only thing that's ever been shown. And if you think about it, if you think of your body like a car, right? The less mileage you put on it, the longer the car is going to last. So when you're on this medication and you're eating less calories, you're also reducing your metabolism, which means you're reducing the amount of energy your body has to expend on a daily basis, and you're decreasing the amount of cell turnover. And so
how does this compare to intermittent fasting?
It just makes intermittent fasting easier. So this is the thing with intermittent fasting. I've had some people come in and say like, oh, I do intermittent fast. So a lot of my obese diabetic patients, they intermittent fast. They don't eat all day and then they just eat all night. That's not good. So intermittent fasting works if the amount of calories you're having in total for the day are in check. If you don't eat for, 16 hours and then you only eat in an 8-hour window, but you overeat and eat unhealthy foods, then intermittent fasting is not going to be a benefit to you.
But if you have the same calories throughout the day versus intermittent fasting and binging it all, it's still maybe better to do the fast because your body goes into a catabolic state, no?
So yes, it will. So it uses your own stores during that catabolic state. But if you're eating so much that your body still has the glycogen, then it's not really doing much.
Right. In terms of Ozempic long-term side effects, you mentioned all the side effects short-term, like the nausea and stuff like that. And assuming you hit a dose that a patient tolerates it, are there any documented long-term side effects that we have to warn patients about? Because we see tons of patients on it now who are coming for facelifts. And there was all sort of stuff about anesthetic considerations, which came about initially with gastric emptying. And then there was some stuff about not only losing fat, but losing muscle mass. So what's your general sense of that?
So in terms of long-term studies, it's hard to go there, right? Because these drugs haven't been around that long. Right. Like I said, I think the longest I've had a patient on it is almost 10. I think it's just coming up on 10 years, like, with it. So I don't know the longest-term studies. But what we're seeing in, what we can extrapolate is that, yes, if you lose weight rapidly, and if you lose weight by not eating a healthy diet, like if you're not eating enough protein, if you're not eating enough nutrients, if you're just eating 1,000 calories a day of junk food and cookies, then yeah, that's not healthy. And you're going to have a side effect associated with that. You're going to lose muscle mass because your body needs protein to preserve that muscle. I will say, though, that when we look at patients before they start the program, we do an analysis of their muscle mass and their body fat composition. And I'll tell you, a lot of the patients starting off that are obese or overweight also are over-muscled. We often see them correlated, that they actually
don't hear
have
about that very often.
I know, but so when I do this test, they're overweight, but they also have a lot of muscle. So they have some room to lose. And with any diet, whenever you lose weight, you're always going to lose both fat and muscle. It's just, that's what's going to happen. So in order to prevent it from being too extreme, we want to prevent people from rapidly losing weight. So we still want to keep it in a healthy 2 pounds per week. It's usually more at the beginning because they're losing their glycogen stores as well. And whenever you store 1 part glycogen, you store 3 parts water. So they're going to lose that water weight at the beginning as well. But then it's usually not that crazy rapid. It's 1 to 2 pounds per week. Make sure they're having, protein. We teach them the right amount of protein to eat. And yeah, so then I don't think the loss of muscle is that big of a concern if you manage it. The ones I worry about are the patients that come in that say, I really want to go on this, and they don't really need it. They maybe have like 5 pounds to look better in their genes, but do they need to lose weight from a health perspective?
So what do you do
No.
with that person?
We don't start. And if I look and I see that they're on the low end of muscle, that's someone I'm not going to start.
But what about for longevity?
Then they don't need it for long. They're doing the right things already. I don't know yet, and I'll look at studies for this, I don't know yet if it has a benefit for longevity beyond the change in body composition. So there are reports that it helps with, cognitive health and inflammation, but I don't know if that's independent yet. If that would still be a benefit in someone.
It would make sense that it would be for longevity. If you go to Peter Attia's concepts of the 4 horsemen, it's improving all of the things that are going to eventually kill you, right? So,
but already those patients
cancer,
the patients that are already very thin to start off with, and they just want to lose a fashionable 5, usually they already have low inflammatory markers, so I just worry about the cost benefit of maybe if you got some benefit, but if they lose extra muscle, then you have to look at the risks associated with frailty and falls and fractures.
Yeah. I meant longevity for the patients who are clearly it's indicated. The heavier patients,
and then I think it's great.
For someone who's totally healthy, probably it's less definable.
Yeah, I think more patients should be encouraged to take. We often think, in medicine, we're taught do no harm, right? And often we think of that as don't give an intervention that's going to cause harm. But sometimes by lack of doing something, you could cause harm. So if I see a patient that could lose 10 pounds, 15 pounds, by me not suggesting that they consider this medication, I might potentially be doing harm to their lifespan and health span. So it's a conversation that I have with a lot of patients.
Thanks so much for listening to Unfiltered, episode 1 on our longevity series with Dr. Melissa Hirshberg. We'll be back with part 2 longevity series with Dr. Melissa Hirshberg soon.